I'm going to start by just showing you some pictures that are going to put into perspective some of what Dr. Gittleman was saying. So when we talk about breast cancer, the vast majority of breast cancer is sporadic, which means we don't know why it happens. And there is 15 to 20% that is, okay, cancer runs in my family, but then there's this 10% that's hereditary, and that's what we're talking about with the BRCA gene. So when we take a look at the BRCA gene, there's actually multiple genes that you can test for. There's the BRCA1, BRCA2, and then there are other genes that are unidentified yet that we don't even know about. And with breast cancer, the vast majority of breast cancers are due to the BRCA1 gene and then followed by the BRCA2 gene. And as Dr. Gittleman said, there's also a very high risk of ovarian cancer associated with the BRCA1 gene especially, and also with the BRCA2 gene. So if you take a look at the general population, which is in the purple color, and the red color is the BRCA1 and BRCA2 patients, you can see how much higher their risk of breast cancer is. At first, when they're 50 years old, they have a 50% chance, and then in their lifetime, up to a 90% chance compared to about 10% of the general population. So this is why you would want to be tested. I can't stress enough how I have patients come to me and say, well, why would I even want to know that? You know, I don't want to, just sit around and be waiting to get cancer. Why would I want to know that? Why would my children ever want to know that? Because there's a lot that you can do about it. And your chances are so high that you can actually get the cancer that it is worth knowing because it's worth doing something about. And this is also important for our patients who have already had cancer, for example. Sometimes I see patients that have had cancer 20 years ago, and here they were in their 40s when they had it. This is why I like to test them still, because they still have a 50% chance of having a second breast cancer. Okay, so even just because you already had the breast cancer doesn't mean you can't get another one, and then you're still at risk for the ovarian cancer. And this is just depicting that, basically. The general population risk, and then your BRCA2 and BRCA1 risk, very high chances of getting ovarian cancer. And then we can't forget about the men. So this is an autosomal dominant gene, meaning that you have a 50% chance of passing it on to your children. Well, the male children get it too, and if they're positive, they can pass it on to their female children. Okay, so then their risk would be just as high. But males, it would also increase their chance of getting breast cancer. Now, it's a 6% lifetime risk. An average woman's lifetime risk is about 10%. So it's very high for a male, but still not that high compared to the average female's lifetime risk. But it also increases their chances of prostate cancer. So that's why it's important for them to know too. And then there's also colon, pancreatic, melanoma, gastric, and fallopian tubes, which are associated with the ovaries. So it's not just breast and ovarian, but there's other things involved too. So it is very good to know about it. So what do you do with the test results? So you go in, you've been tested. There's 3 different possibilities that you can get. The first is positive for a deleterious mutation. Okay, I have the gene, now what? The next is completely negative. So that basically puts you back at the risk as when you walked in there. So you may still be at high risk for developing breast cancer because your family has had breast cancer, but you don't carry the gene, and so you don't have that very, very high risk for breast cancer. However, we then at that point would do that Tyrer-Cuzick or the Gale test, those models that Dr. Gittleman was talking about, and if your lifetime risk for breast cancer is above 20%, we would screen you closer with MRIs, mammograms, and more frequent breast exams. And then the third possibility is the genetic variant of uncertain significance. So the genetic variant of uncertain significance, that means that they tested that gene. There's some kind of mutation going on there, but we don't know what it is yet. So they're going to hold on to it, the genetic lab, and they're going to keep doing research, and if anything changes or they discover anything about it in the future, they will let you know. That doesn't happen too often, but when it does, then it's sort of a question mark. So what are our treatment options? There's basically 2 big lumps. We could either do non-surgical or surgical treatment. So under non-surgical, it's basically increased surveillance, so we keep a really close eye on you. Every 6-month breast exams, mammograms, MRIs, and we'll talk a little bit more in depth about each one of these, and ovarian cancer screening and chemoprevention. Under the surgery side, we're talking about bilateral mastectomy and oophorectomy. So increased surveillance. You're already getting your yearly mammograms, and we would normally start at the age of 40. However, for patients that are BRCA positive or high risk, we would start at the age of 25, or at least 10 years before your youngest affected family member, okay? But then if you're actually high risk, we add MRIs to that. So we usually try and stagger them every 6 months. So we're taking a look every 6 months. A lot of patients come to me and they say, well, what about radiation? I'm going to be getting, mammograms and MRIs. You don't get any extra radiation with MRIs. It's a magnet, so you don't have to worry about that. And then we also do every 6-month breast exam. So I would usually stagger that between myself and the patient's GYN. Ovarian cancer screening. What we recommend, or what the recommendations are by the guidelines, is every 6 months you would have a pelvic exam, transvaginal ultrasound, and a blood test, the CA-125, which is a tumor marker for ovarian cancer. Unfortunately, all 3 of these put together are still not very good at actually detecting ovarian cancer, and that's why we really stress actually undergoing the ovary removal procedure. A lot of times this does not pick it up until it's too late. And then something called chemoprevention. You may have heard of tamoxifen. Essentially, you would be taking these patients that are at high risk and putting them on tamoxifen, 1 pill a day for 5 years. And what that does is it decreases your chances of getting breast cancer by 50%, which is very significant. However, people don't tend to like the side effects. It does have increased risk of blood clots, hot flashes, which is the biggest complaint from patients. It can increase cataracts, a very low chance, but uterine cancer as well. So you kind of, have to take a look at your risk and weigh the risks and the benefits. The guidelines have been established to take this because if you are at high risk, then the benefit is thought to outweigh the risks, but you also have a personal choice in that. Also, if you are BRCA positive, especially BRCA1 patients tend to have estrogen receptor negative disease. So tamoxifen actually doesn't help you that much. And that's another reason why surgery is a kind of a better way to go. And then also there's other medicines aside from tamoxifen, but tamoxifen is the most popular one. So preventative surgery, what does that entail? Basically, we would be doing bilateral prophylactic mastectomies, and we could do immediate reconstruction at that time. We are doing nipple-sparing mastectomies now, so basically we make the incision underneath the breast where you can't see it, and you get to keep your own nipples. So it actually looks quite natural when the reconstruction is done. It's about a 2 to 3 hour procedure. It's usually about a 1-night stay, and about 2 weeks you can go back to work. So why surgery? And why am I biased towards the surgical option aside from the fact that I'm a surgeon? Well, there's a couple reasons, and there's 2 studies that I would like to point out to you. The first one showed 105 BRCA positive patients who underwent bilateral mastectomy and compared them to 378 patients who underwent surveillance. In the arm where there was mastectomies, there were only 2 reported cases of subsequent cancer. Out of the 378 patients, 184 ended up getting cancer, okay? So in my eyes, why would you wait to get the cancer, wait for it to happen? And when these cancers actually happen, they tend to be pretty aggressive and happen rather quickly and can sometimes spread faster than other cancers, so they're hard to catch. So that's a 90% risk reduction with surgery versus surveillance. So that's why I would recommend it. And another study showed 76 patients, a smaller cohort, but 76 patients who were BRCA positive who underwent mastectomy, and there were 0 reported cases of cancer versus 63 who underwent surveillance. And the scary part is there was 8 reported cases of cancer, however, 1 death. That's the really scary part. That's what we want to avoid. And so That's why it's a little safer to go with the surgical option, but you can always decide. The preventative surgery for ovary removal. So we recommend that that be done by the age of 40 or as soon as you're done with childbearing. And this is actually good for both reasons. It not only decreases your chances of getting ovarian cancer by 96%, but it also reduces your risk of getting breast cancer by 50%. And that's because of the estrogen that you would be removing with ovaries. And this can also be done laparoscopically, meaning minimally invasive with the tiny incisions in the belly button without a big incision. And a lot of times we can do this at the same time as the mastectomies. So it's one surgery in and out. We don't want to forget about the males again. So the recommendations are not as clear for males. We definitely recommend every 6-month breast exam starting at the age of 35. It's not it's not mandatory that they have mammograms, but it is recommended to be considered, especially if males have gynecomastia, which is the development of male breast, actually breast tissue. So then we would definitely recommend the mammograms every year. I have heard of males undergoing prophylactic mastectomy. It's something that can be considered, but not required. And of course, this is very helpful, the early prostate cancer screening, because their chance of prostate cancer is elevated. In addition to the surgical and non-surgical options, these are just some lifestyle modifications that can be done to decrease your risk of getting breast cancer. Physical activity, 3 to 4 hours per week, and it doesn't have to be very aggressive, but walking would be fine. Weight loss, but not weight loss, but really just being a healthy weight. Obesity itself is it increases your risk of getting breast cancer because fat cells actually can produce extra estrogen in your body. Limiting alcohol intake to do 2 drinks per week is really the recommendation in the literature. That might not be, I know. I don't practice what I preach. But I mean, well, that's really what's, the studies have shown, but the less alcohol intake, the better for your risk of breast cancer. Breastfeeding, and the earlier that you have children. So breastfeeding will decrease your chance of breast cancer, and the younger you are when you have children will decrease your chances of getting breast cancer, and then also having normal vitamin D levels, okay? And you can talk to your primary doctor about checking your vitamin D and making sure that your normals are level.
Did you just say breastfeeding increases your risk of breast cancer?
I'm sorry, it decreases your risk of getting breast cancer. Sorry. And then just some final thoughts. This is definitely an emotionally charged topic. It can be sometimes ethically controversial to people. Some people don't want to find out because they don't want to feel like they're responsible to tell their relatives, or they don't know how to, or they feel like they're responsible for their relatives being sick if they do have it. But the bottom line is it's the wisest decision to be tested and to know and have your options open to you and to your family members so everybody can do something about it if they choose to. And so if you do get tested, it is important to let your family members know that you've been tested, advise them maybe they should be tested if they're indicated to be. And also I get a lot of questions from patients saying, well, I don't want this because I don't want it, it's gonna be more difficult for me to get health insurance then. Or what if a job doesn't hire me because they know that I have this and I'm eventually going to have to, have this surgery done. That is against the law. There's something called the GINA Act, or the Genetic Information Non-Discrimination Act, and essentially that prohibits the use of any kind of genetic information in employment or health insurance claims or anything like that. So they cannot discriminate against you for having a predisposition to any sort of disease. Okay? And that's it. Thank you very much.